Yes, the next speaker is Chris Logothetis. He will be talking on novel agent, the perspective on novel agents, including PARP inhibitors.
Thank you very much, Silke and Aurelius, for being wonderful hosts, sharing your town with us, and setting up this wonderful venue that really has created a fertile environment for discussion. So I took the privilege of being undisciplined and slightly changed my topic because I see that the challenge and the consensus need to be arrived, not only how to select targets, but actually bridge the distance between target identification and application in the human, which requires context. So, the agents being developed are being developed as single agents. As many of you know, we've made very little progress in complex adult solid tumors in applying single agents. So in need of effective sequences or combinations. That's what we need our novel combinatics for. So when we develop drugs, we have to anticipate how we're going to give them in combination. Predictive markers largely absent, and serial sampling of tissue is very difficult in prostate cancer. So the absolute need to both identify markers and develop easy ways of monitoring disease longitudinally is critical to the effective bridging of the gap between the dream of a new target and its effective application clinically. And clinically, the disease is heterogeneous. Molecular profile is not applied clinically, so the notion that we can develop drugs in an environment we have access to this and then deploy them broadly in unique subsets is still very challenging, and it's not scalable. All these things are going to have to be done contemporaneously with the drug development in order to make advances, so I would like to link these two concepts as what I see. So this disease is very dynamic and it changes over time, and our preferred model is the one that's following, and we use this spiral of progression because through a large period of time the disease stays in bone, and it's iterative, interactive, mutually directional way between bone and epithelium, stroma and epithelium, before it merges and becomes resistant. And while the topic is not AR signaling, what I'd like to point out is something that Eleni spoke to earlier, and that there may be a subset of disease that is somewhere between the castrate-resistant progressive disease state and the hormone-naive state that we're calling persistent disease. And this one is resistant by every morphologic criteria to androgen ablation when you look at the specimen, but when you examine the genotype, you see marked alterations in androgen biosynthesis, and you don't see the emergence of the changes that are characteristically associated with castrate-resistant and metastatic disease. This raises the question is, what do we treat these patients that by morphologic criteria are castrate-resistant and metastatic, and they have a set of targets associated to them? And in this setting, there are GR, PR antagonists, N-terminal AR that needs to be, glutaminase is being targeted, CDK4 and 6 inhibitors, steroid biosynthesis alterations, PI3 kinase, and MEK. There's alterations in hyperproliferative states without alterations in RB, P53, or the ARV7 variants, or what we know to be disease. It's a very specific disease state. By morphologic criteria is absolutely resistant. By genetic criteria is completely different than the castrate-resistant metastatic state. So I would like to contextualize drug development, and many of these drugs are in trial in these disease states and in more advanced disease states, and they may have completely different results, and I anticipate some answers from this within the next year and a half. So the next one is what happens when the disease migrates to bone and what happens when we treat the disease in that site. And the poster child for this is, of course, RAD223, which is characterized by prolongation of survival, improvement in tumor-associated symptoms, but absence of decline in PSA concentration or myelosuppression to a significant degree where the tumor resides in the marrow. Taken together, this is a very specific profile of response that we think is associated with microenvironment targeting, and the question is which novel agents are coming that are going to be in this category. And the important thing in favor of this is when you look at RAD223, not only does it improve bone formation, as Nora Navone showed in the PDX, in the tumor-bearing bone, but the contralateral normal bone also shows bone formation. So this is an anti-osteoclast drug that targets the bone in a very profound way and actually grows and strengthens the normal bone and not the tumor-involved bone as well as the tumor-associated bone. So FGF signaling is one of our preferred targets. It's going into the clinic in a number of ways, and it occurs in two settings that's important to understand. One is autocrine FGF, where the tumor cell produces its own FGF, and it continues to grow in an autocrine pathway. And the second one is paracrine FGF, where there's an interaction between FGF that's in the osteoblast and the one that's in the tumor cell. And here's the results of a clinical trial published by Dr. Korn and Dr. Navone in its co-clinical compartment. And what it shows is this characteristic response that we also saw with cabozantinib: decline in ALK phosphatase, decline in bone turnover markers, marked improvement in bone scan, rare patient who had regression of soft tissue disease, no effect on PSA. Again, a very typical microenvironment targeting agent, exactly like we saw with cabozantinib. So these drugs are going to require context development, which requires us to be able to understand and monitor the effects on the microenvironment, and in turn, secondarily, look at its effect on the epithelial compartment. There are several drugs that are going into the clinic: FGF, Wnt, MET, VEGFR2 inhibitors, osteoblast, osteoclast inhibiting strategies, RAD223, and the PSMA targeting with lutetium, which all targets different components within bone. Each of these affect cabozantinib. It needs to be reconsidered, is actually an endothelial targeting agent. It's not that MET, you get the same anti-tumor activity where MET is expressed or not in the epithelial compartment. Several trials are ongoing in these. We should have some indications on whether we can build on them in combination, and companion trials in order to develop markers to monitor the efficacy and select patients are also being considered. Now, I'm going to take a quick look because for me, as a non-immunologist, I consider a macrophage an osteoclast. Our immunology colleagues call it a macrophage. You know, these interact a lot. And what I'd like to say is the genotype and the antigenic load does not reliably predict consistently on responses or patients who benefit from Ipilimumab. In fact, we do see within the classic acinar adenocarcinoma evidence that the genetic altered, the mutational load does crudely correlate with probability of benefit. But the patients with the highest mutational load had no response, and they were both in the aggressive variant subset, indicating that there's an interaction between mutational load and underlying driver biology that may account for this. However, the immune system is tricky, and when you poke it one way, it responds another way, and here are targets that target other cell partners. You can see when you challenge with androgens, and this is CyTOF on this large trial run now by Anna Aparicio, and we collect specimens in the marrow. These findings are not found in the blood, and you see immediately increase in CD68, PD-L1, and VISTA, targeting another counter-inhibitory agent that inhibits immune response. So we're going to have to develop combined microenvironment targeting agents and inhibit the microenvironment targeting component which inhibits immune response in the context of bone. So VISTA, daratumumab, PD-1, CTLA-4 in combination, and YAP inhibitors are all being developed and tested in this setting. So finally, there's the emergence with the cell autochthonous targets, the one that is favorite, and we now have markers that suggest in a randomized trial who will benefit from platinum, and Anna Aparicio and Paul Korn would suggest that there's a subset of patients where depriving platinum of them, it would be maybe a mistake. This data obviously needs to be confirmed, but this is a randomized trial for molecularly defined patients with aggressive variant prostate cancer, and you can see with the addition of carboplatin, the negative effect of this prognostic category disappears. The absence of platinum, they do much worse. Not only is there a higher response rate, which she observed and presented at GU ASCO, but also that you ablate the negative effect of this subtype with the addition of carboplatin. So this would be, if confirmed, the first data suggests that there's a subset of men who are uniquely sensitive to chemotherapy, a specific chemotherapy, and it would inform the initial use of combination chemotherapy. Now, this is the work of Matteo and Bono and his group, and this has done a wonderful association between molecular markers and the probability of benefiting from a PARP inhibitor. These data obviously need to be confirmed. The complexity within this heterogeneous group of patients with DNA damage repair deficiencies will need to be known. So I think within the next year, we will know who these people are, we will have a better sense of who's going to respond to PARP inhibitors. We'll develop a rational understanding what BRCA-ness means and homologous repair means, and we'll be able to define these patients better and begin rational combinations. Without those associations in larger tissue-based studies, it's going to be difficult to get traction on this quickly. So the other question, because we're always in the belief that there's an interaction, is what is the interaction and the overlap between platinum sensitivity and PARP inhibition? And this is a trial we hope to start very soon and hope to have an answer for you in 2 years. And what is the interaction between the determinants of response to platinum and the determinants of response to PARP, and how does platinum inhibition and alteration subsequently affect the probability of benefiting from a PARP inhibitor? Giving the two together seems to be clinically a challenge. So what are we doing in this place? Well, EZH2 inhibitors, YAP inhibitor, bromodomain inhibitors, all targeting the epigenetic regulation, are going into the clinic in multiple institutions, including ourselves. GR, MET, and FGF inhibitors are being targeted here for their autocrine role, not their paracrine role. So they're being studied in a different setting with a different readout being expected in these patients rather than in the paracrine setting. So why encourage, and what do I think will happen in the next year to two? Agents have been developed as single agent. We have candidate therapeutics that have been linked to disease state, and interaction with other therapies has been proposed. We will have confidence on the effect of the interactions in the disease state, and we will be developing disease state-specific therapies. I gave you a menu of what these are. Predictive markers absence and serial tissue sampling is difficult. Liquid biopsies in institutions that do this are present, they're used, they're informative. We're not able to scale up. I think the problem of scaling up will be addressed in the next 2 years. And clinically heterogeneous, might I tell you that 60% of men with metastatic castrate-resistant disease can be defined into either being highly responsive to hormonal therapy or highly resistant. We forget at that. It's alien to me that we talk about this as a uniform disease. I believe that that will be applied in the next 2 years, and we'll be talking about these two subsets. I think the third subset of microenvironment-dependent bone disease has yet to be clarified. That'll probably emerge in the next 2 to 3 years. So thank you very much.
Any question?
So no, I think, Chris, as always, that was such a philosophical talk that we omit the questions. Obviously, nobody dares to ask one.